Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hi friends, I'm Dr. Natalie Crawford, and welcome back to the As a Woman podcast. Today we are talking about unexplained versus undiagnosed infertility. And I'm going to dive in on my take on this and some general thoughts if you find yourself into the unfortunate category of having unexplained infertility, which I myself am in your club. Before we dive in, I just want to say, number one, thank you so much for your support of the podcast. Number two, if you haven't, you should sign up for the newsletter. The newsletter you can sign up for at nataliecrawfordmd.com/newsletter. We have really exciting newsletter content that is ramping up as we get closer and closer to announcing the pre-launch of Balancing Act, which is going to be my new fertility book. So very excited to just finally take some of this information and share what I've been sharing on social, but in a more tangible, actionable form. So for the newsletter, we have weekly newsletter updates with some of my favorites, some recipes. You get a link to the TTC Starter Guide, which has information on cycle tracking and lifestyle. There is some exclusive upcoming events, including some Q&A sessions, webinar access, and even more fun things to come. So easy to sign up for that. Also want you to know that we do Q&A episodes here on the podcast and on Instagram. You can ask your fertility questions on Monday at nataliecrawfordmd, and these questions will be answered either on Instagram, here at the end of some of our podcast episodes like today, or you'll even see some of them answered in the newsletter. You also can call and leave a voicemail. My favorite episodes are your voicemail questions. 657-229-3672 is the voicemail. Again, that's 657-229-3672. I can't give personal medical advice. I can't give you an IVF protocol, but we can talk about what I wish you would know, questions I might ask if I were you, and help you get the information you need so that you can advocate for yourself. Have to give a plug that if you're going through infertility, you really want to take charge of things, I do have the Enhance Your Natural Fertility course, and I've got the IVF guide. This goes into detail on protocols and red flags, and the Enhance Your Natural Fertility course is really about lifestyle factors, includes a lot of information on supplements, and access to the community, which I help moderate, answering some of your fertility questions. You can find out more about both of those over on the website, nataliecrawfordmd.com. Unexplained infertility is an official diagnosis of infertility. I don't want you to think that undiagnosed is an actual category, but a lot of us, myself included, will say that we don't really believe in unexplained. I put it in your chart. It's real. But what it really means is that you didn't fit into one of the big, easy to diagnose categories. And I think that that's really important. So what is infertility and what are these categories? So remember that infertility is defined by the absence of an event. This is a reactive field. So if you have regular periods, you're able to have intercourse, and you don't get pregnant after a year of trying, and you're under age 35, that is now the definition of infertility, and you should come in for a fertility evaluation. If you're 35 to 40, we recommend the evaluation at an earlier time period after 6 months of trying, and if you're 40 and older, 3 months or less. Time is of the essence. You do not have to have proven infertility to get a fertility evaluation, at least not in most places anymore. That was the case for a while. You would tell your doctor, we've been trying to get pregnant for 7 months, and they'd say, too bad, you're 34, got to go try for 5 more. And you might encounter that. However, I'm a believer that you should be able to get fertility testing if you want it. This is basic information, and you shouldn't have to prove that you're having a hard time doing something in order to get the testing. Now, a lot of people will say insurance isn't going to cover it, or you're not going to qualify. That's really not true in a lot of cases. Fertility testing can be covered even without infertility. It's coded as fertility testing. So if your insurance has coverage for fertility testing, it does either way. And a lot of people don't have insurance either way, so why are you being forced to wait this amount of time? Importantly, will a subset of people get pregnant if they wait the extra amount of time? Yes, that's what these numbers are built off. Numbers to define what is infertility and what is not is when do some people fall off the bell curve. However, if you're under age 35, vast majority of people will be pregnant by 6 months. A small secondary group will get pregnant in those next 6 months. And people will get pregnant in the year or two after that, just the numbers drop profoundly. It's important to remember that even when you're your youngest, healthiest, not everybody's going to get pregnant. Your monthly chance of pregnancy is called your fecundability, and at your best, that's going to be about 20 to 25% per month. As you get older, that number decreases. Also importantly is that when you look at the number of people who aren't going to be pregnant that 1 year mark, that's increasing over time. We see more people being diagnosed with infertility. Used to say it's 1 out of 8, now globally 1 out of 6, and in the US, if you're trying to get pregnant for the first time, you have a 1 out of 5 chance of having infertility. That's a really big group. And so we are seeing that the number of people who achieve success in that secondary 6 month dropping more and more. So again, if you have a hint something's wrong or a gut feeling or you want a big family, you're getting started at this late, or you just want to know, you should be able to ask for fertility testing. And if you're hitting a roadblock, call a fertility clinic. We are happy to help you. We have a very different perspective. What is fertility testing? Fertility testing is meant to detect the top causes of infertility, meaning what is going to fit the category for most people. So again, if we look at older data, it's a little bit different now. But if we look at the length of time to pregnancy in people who are under age 35, 57% of people pregnant after 3 months of trying. 72% after 6 months, 85% at a year, 90% at 2 years. So that's a small number, between 72 to 85%. 13% of people will get pregnant that second 6 months, whereas the bulk of them got pregnant in those first 6 months. When you go from 1 year to 2 year, you're already past a year of trying, you really have a minimal increase in your probability of pregnancy. Only about 5% chance that full year, or 5% of people will get pregnant. So that's really why we don't want you to keep trying without knowing what's going on, especially if you want to have more than one child. So when we look at what the top causes of infertility are, we can say that when we look at couples, we've got tubal and anatomic factors accounting for about a third. We have male factors accounting for 30 to 40%. We have ovulatory issues, 15 to 20%. And we've got unexplained infertility, we usually say is 10 to 15%. Now, what's not in here as a cause of infertility, even though it really is one, is age-related factors. So we know in every fertility doctor, if you say, tell me about age and fertility, I will near guarantee the words that'll come out of their mouth is, age is the number one predictor of your fertility. Because that's what we're taught, and that's a true factor. Your eggs sit inside your body your whole life. They absorb the wear and tear of the world around you. And the chromosomes inside those eggs, which is what your DNA is, they degrade, they move positions, they lose their stability over time. We know this happens in your cells. This is a part of physiologic aging. This is why you get wrinkles and back pain, why people can get dementia. Our cells don't stay as stable in order to do the job they need to do the longer that we've been alive. But really, and maybe more importantly, the more they've been exposed to, the more inflammation that they've had, the more toxins they've been exposed to. So these numbers that we learn and we quote, very interesting because we don't ever say this percentage is due to age, even though it's going to be the number one category of people I see. These things are all going to come back normal, and I'm going to be left with either unexplained or age-related factors. And a lot of those go hand in hand. But let's talk about testing. So in order to understand your age is your age, I'm going to talk about percentage of normal eggs at your age. Decreases as you get older. Number 2, let's talk about running out of eggs. And this is a hot topic, big debate here. I believe if you ask, you should be able to get tests of your ovarian reserve. There are 2 ways to test your ovarian reserve. A blood test called AMH and an ultrasound for an antral follicle count. FSH, estradiol are not used anymore to test how many eggs do you have left, which is what ovarian reserve is testing. The analogy I always use is how many eggs do you have left inside that vault? So again, imagine you're born with all the eggs you're ever going to have. They're kept in a vault inside your ovary. Every month, a group of eggs come out of that vault. From that group, one is chosen to ovulate, the rest die. But the number of eggs sent out of the vault is dependent on how many you have remaining. When the vault is more full, sends out more. When the vault has less, it sends out less. The number of eggs that comes out of the vault is dynamic. It's not going to be perfect month to month, but you can evaluate the eggs outside the vault and get a surrogate marker for how many are on the inside. AMH lives in your blood. It's made from the cells that surround each egg, and so it gives you an idea of what has been happening in the past few months. It can be influenced by the world around you, taking birth control pills, not ovulating for a long time, being pregnant, breastfeeding. Those things can change your AMH. It doesn't change your egg count, doesn't change your fertility, but it means the cells have been downregulated to make less AMH, so that number may not be accurate if it comes back low. I still check patients' AMH when they're on the pill, and here's my spiel. Hey, you're taking contraception that might cause your AMH to be lower than normal. However, you're happy on this because you don't want to get pregnant right now. I think it's reasonable to check an AMH, and if it comes back normal, we feel comfortable that you're not running out of eggs right now. But we understand if it comes back low, we might want to stop this hormonal contraception for a few months and reevaluate or refer you to a fertility doctor. That's what I would say if I was an OB, in order to get a better understanding of how many eggs you really have left. People can understand that, and you can still make a decision to get the data. Saying, I can't check this because you're on the pill, false news. And then an antral follicle count is an ultrasound determination of how many eggs you have in that month. The eggs are microscopic, you can't see them, but each egg grows inside a small fluid-filled structure called a follicle. So that's an ultrasound determination. A little bit more invasive than a simple blood test like AMH. Fertility doctors love both. That gives us the most information. In general, you run out of eggs as time goes on. However, people do run out of eggs early in other scenarios, going into ovarian failure early, endometriosis, other autoimmune or inflammatory disorders, having prior chemo or radiation, and that information that you have a lower egg count might impact your future decision. The reason why this is so controversial, and I think this ties in a lot to people who have unexplained infertility. There's so many people who walk around with an unexplained infertility diagnosis who have a low egg count, because what we've been taught, based on the studies that exist, is that having an AMH that's low should not impact your ability to get pregnant. It does change how many eggs you have available in a given month. That significantly impacts your rate of success per cycle with IVF or egg freezing. It likely also correlates with your reproductive longevity, how much time you have to grow the family you wanted. But something I've always said is that it depends on why. Not all reasons that lead to a low egg count are the same. And if you have a low egg count because you have endometriosis or an autoimmune disease, that chronic inflammation is likely also impacting the egg quality and your ability to get pregnant. Prior studies have shown no impact on time to pregnancy based on your AMH, but a newer large study just showed that in women with a lower AMH, 1 and less, they had a longer time to pregnancy. Another way to say that, a higher rate of infertility. So I have always said that a low AMH, especially out of proportion for your age. I mean, everybody's going to get low at some point, but if you're a 30-year-old with a low AMH, why? What is going on? Your fertility doctor may not be able to get to the bottom of this, but you've got to bring all of the information. And I bet you have unexplained infertility. So what really is unexplained infertility if age and egg count don't go into categories that get to count as what the top causes of infertility are? So tubular uterine abnormality, so having blocked fallopian tubes, dilated fallopian tubes, having an abnormal uterus, maybe you have scar tissue inside or fibroids inside or something else structurally abnormal. You can detect these by doing imaging. A normal transvaginal ultrasound isn't enough. You're either going to need an HSG, a hysterosalpingogram, and X-ray dye test. You're going to need some combination of a saline sonogram with a FIM view, or where they push foam or bubble something through the fallopian tubes, or surgical evaluation with hysteroscopy, camera in the uterus, and laparoscopy, camera in the abdomen, to evaluate both uterus and tubes. A transvaginal ultrasound is only telling us part of the picture. Tell me about the muscle of the uterus and tell me about your ovaries. It's important. It's like one of my favorite tools, but it's not telling me about the inside of the uterus, because the uterus is a potential space, and it's not telling me about the fallopian tubes at all. In fact, if I can see your fallopian tube on ultrasound, it's not good. Something's abnormal. All right, male factor. This requires a semen analysis. Sperm changes every few months, okay? So just because you conceived a child in the past or with somebody else doesn't mean the sperm is fine. You need to have a semen analysis now. A semen analysis is evaluating how many sperm you have, how they move, what their shape is, and giving you so much information about the environment that the male gametes are growing in. So if there's hormonal issues, you will often see that in a drop in your sperm count. If there's environmental factors, you might see that in a drop in your sperm motility or shape. There's also some genetic things you can even detect on sperm that look like somebody might have a cystic fibrosis mutation. So there's a variety of things. A semen analysis is a mandatory piece of a fertility evaluation. I say that with such passion because so often women walk in my office ready to take all the blame and they say, the problem's with me, I know it, he's not going to do that. No, ma'am, absolutely not. It takes two to tango. We absolutely need all the pieces of the puzzle because sometimes two things can be true. Importantly, a semen analysis does not detect functionality. It's not testing function of the sperm. The best way to test the sperm function is to try to fertilize an egg with it, and that's IVF. So sometimes you learn more about sperm in the IVF process. You can do a DNA sperm fragmentation, which is a more high-level test. This test has a lot of controversy between it, really looking at the DNA integrity inside the head of the sperm. Origin studies were to see that sperm, which was more highly fragmented, meaning the DNA wasn't as intact, maybe those guys would benefit more from IVF with ICSI. ICSI is a specialized type of fertilization where you pick one sperm and put it in the egg. It's really becoming more standard. So a lot of us ask, does that test add a lot? I think it can be helpful, especially if there's known male factors or we're really seeing poor embryo development. We're not seeing the outcome we want with IVF. I think there is a need for it if we're having failure with treatment. It's not standard to do ahead of time, but I'm also not opposed to it. But it is an out-of-pocket expense. So if we are wanting to be smart as far as doing testing likely to give us results, it's not often a first-line test, but it's not a wrong test to do. And in some circumstances, it might be an important first-line test. Ovulatory function is a huge one here, and that's an easy one. People will say to me every day, I have regular periods every month, but I'm not sure that I'm ovulating. If you're not on hormones, you're not on birth control, you're not taking hormones, and you have a regular, predictable period, you're ovulating. The question might be you're not sure that you can detect it or you don't know exactly which day it's happening, and that can be a valid point, but you're ovulating. Anything else which causes uterine bleeding does not do so at a regular cyclic fashion. Uterine polyps or fibroids, irregularity inside the uterine cavity, endometrial cancer, those things do not cause regular cyclic bleeding. You can have breakthrough bleeding and not be ovulating, but it's not common every single month at a regular, predictable flow and pattern. So if you have that, you're ovulating. Now that doesn't mean everything's perfect, and I always view ovulation on a spectrum. So regular, predictable menses, perfect. You then have shorter cycles where maybe there's some luteal phase issues, maybe there's some spotting in the luteal phase, some type of milder ovulation dysfunction. Then you start to have longer cycles. It's taking you a longer time to get that egg to grow. That's on the longer spectrum. Your cycles are spacing out. Then you're skipping full months, but ovulating some. So these random ovulations, and then eventually you get to no periods at all. So the take home is there's a lot of stages in ovulation dysfunction, but if you say, yeah, my period's coming regular every month at a pretty reliable interval, you're ovulating. I'm not worried that not ovulating is the reason. And if you're having sex, even if you're only having sex once a week, twice a week would be better. But remember that sperm could live in the female reproductive tract for up to 5 days, and an egg lives for 24 hours. So the easy way to get pregnant is not to have to track ovulation and time things perfect and save up your sperm or anything like that. It is simply have sex 2 times a week. Space it out by 3 or 4 days. You're putting sperm there. It can live longer. You'll ovulate, and you're doing it. That works. If you are limiting sex or trying to optimize timing the day of ovulation with having intercourse, there's a lot of different ways we can do that with cycle tracking. I'll tell you, one of the reasons we think cycle tracking is so helpful is not because you're timing intercourse better, but that you have more awareness about your cycles, and when things are not normal, you know about it and can get it evaluated sooner. So ovulatory dysfunction can be from hypothalamic issues, so the brain isn't sending out the right signals. You can be running out of eggs. You can have PCOS, polycystic ovarian syndrome, thyroid disease, prolactin abnormalities, high stress, chronic inflammation, autoimmune disease, a variety of different things can contribute to ovulatory dysfunction. But history is the number one thing that's going to give us the answer about if you're ovulating, not any fancy tests. So this fertility evaluation is actually pretty straightforward. I'm going to get a good history and find out if you're ovulating. I'm going to check a semen analysis. I'm going to check your ovarian reserve. So I can do an ultrasound, an AMH blood test, and I'm going to check your anatomy with some type of internal imaging. We do FemView in our office, can kind of wrap it all into one, but HSG is a more traditional choice. Boom. If you hit one of those categories, ovulation, tubal, uterine, male, then you get one of those categories. Otherwise, you fall into unexplained. Now, many of us will say DOR, which means a low AMH, or age-related infertility, because those things do play a major role in the top causes of infertility for a lot of people. But DOR, as I said, having a low AMH traditionally is not a reason to have infertility, even though recent studies are showing that lower AMHs are associated with a longer time to pregnancy. And this is what I've always said. Why? Why do you have low AMH? And honestly, I see a lot of people who have unexplained infertility as their formal diagnosis, but they also have DOR. And I don't really believe in coincidence. I think these things are connected. This is why I always say, why do you have DOR? Do we know? And that is probably tied to what might be undiagnosed underlying your unexplained infertility. It's hard to get to certain diagnoses. Some of them do not happen, cannot happen within the context of the fertility office. They might happen years later. Potentially, you can aid in this if you bring in your full story and make sure that you give your team all the information. So it's important to think about what can really cause unexplained infertility. And I like to think about this to my patients as, in my mind, unexplained infertility is egg, sperm, or environment. These are things that are hard to test. So egg, do we have poorer egg quality than we should based on our age? Is this tied to chronic inflammation or autoimmune disease? Is the egg growing in an environment? Has there been some exposure contributing to lesser egg quality? Is there something with the sperm? Is the sperm getting damaged in the ejaculatory tract? Is there toxin exposure to the sperm? Even though the sperm might have normal counts, can it do its job? Can it function? And if we think about environment, your whole body is one piece. We always like to think about inflammation and autoimmune disease and understand that egg and sperm have to be able to meet. The internal environment inside the fallopian tube has to be conducive to a very sensitive process, which is fertilization and early embryo growth and development. We know that's hard and highly sensitive because when we first started doing this in the lab, it was really tough to get embryos to grow past day 2 or 3. That took years of scientific research. So embryos are so sensitive to the environment, the pH, the temperature, and the toxins that in my brain, if you have a lot of inflammation happening, that can really hinder fertilization, early embryo growth, implantation. And what are examples of things that can cause egg, sperm, or environmental issues if we think of those of the categories within unexplained or undiagnosed infertility? So some of these could be endometriosis or adenomyosis. Endometriosis is a chronic inflammatory condition on the autoimmune spectrum where essentially endometrial-like tissue, or the endometrium, what you bleed off in your period, is found outside the uterus. That causes a lot of inflammation, and that chronic inflammation can lead to scar. Diagnosis by surgery, sometimes you can find it on ultrasound, and people are working on other ways to diagnose it. But we used to really think endo impacted once you got to those later stages and you had the anatomic changes. But truly, I think the most damaging thing is some of that inflammation, and we see DOR associated with endo and much lower pregnancy rates. Adenomyosis is similar. It's where you have that endometrial-like tissue, but inside the myometrium, which is the muscle of the uterus, almost exclusively seen after there's been some broach of the myometrial cavity, which is typically with a placenta. So prior pregnancies or prior surgeries on the uterus could be something that could introduce the endometrial tissue into that myometrium, and that's a highly inflammatory state. That can usually be seen on ultrasound or MRI. We also have endometritis, which is a chronic inflammation inside the uterus itself. You can diagnose it with a uterine biopsy. You can treat it with a couple weeks antibiotics. People do both. I tend to often just treat with some antibiotics. Some people biopsy and treat and biopsy and treat. One way is not proven to be better, but you can have some inflammation inside the uterus itself. So those are all different things, but all inflammatory disorders. We have autoimmune disease on a whole, right? Autoimmune disease is so hard. It's increasing. If you know my story, I got diagnosed with celiac disease a decade after I had my pregnancy losses and infertility, and had no idea that that's what was going on, or at least contributing. So having inflammation, we know that having autoimmune disease, variety of different types, can result in lower egg count, premature ovarian failure, infertility. And I view a lot of patients, especially if you start digging into family history of autoimmune disease or some of their vague symptoms, honestly sound like there could be something autoimmune going on. Problem with autoimmune disease is you have to be really sick to get the diagnosis in the traditional pathway, meaning antibody levels and cutoffs have to be a certain set point to flag positive. And a lot of my patients, a lot of you guys are taking really good care of yourself. You're trying to eat clean. You're trying to decrease your body's inflammation. So some of these antibodies might not flag positive, even though what's happening inside your body is not normal. I always say this, hey, that's considered the preclinical phase where somebody's exhibiting symptoms of some autoimmune disease, but they're not getting that diagnosis for usually 7 to 10 years. If we can delay the onset of that disease, whatever it is, and all the associated things that come with it, the longer the better. That's just even more proof why focusing in on decreasing your inflammatory burden is so important right now. We should absolutely check for what we can at the moment. A lot of times that's Hashimoto's. You can check for diabetes. You can check for sometimes celiac disease, but that can be a really tough one. You can do just an ANA and see if it flags positive, which might lead you down a different pathway. A lot of times this is where the vague symptoms you might have or your family history is very important. Are you gaining weight, losing weight? Do you have fatigue, brain fog, insomnia, or sleeping too much? Joint pain, back pain, migraines, what might be going on? GI trouble at all? Dry mouth, dry eyes. There's so many different symptoms that can point down different pathways. And I've sent patients to neurology or to rheumatology because I think they have such a high likelihood of having something based on their symptoms to try to help us get to the answer. What I think is so important to understand is that the traditional fertility evaluation is catching the big things. Anatomical issues, not function, but are your tubes open? Is your uterus normal? Sperm, number, and motility. If you ovulate. And when you fall off of those track, there's a whole lot of things that the diagnosis will only really come into based on what you're telling me. And so I have to know what to look for. Some things I can't look for, but I can refer on. But I like to think about it as these things in my brain, unexplained infertility, egg sperm quality environment, really are connected by inflammation as their connecting piece. Is there some exposure causing inflammation, some disease causing inflammation? Can we change that? How can you improve the inflammation? You can. Sometimes that's enough and sometimes it's not. Can we get to a diagnosis? Sometimes it doesn't make sense. I have patients who I say, I think you have endometriosis, but because of this factor, I think the recommendation is to make that presumption, do a protocol for that, do IVF, and not go through the surgery because of this scenario. Really, this is personalized medicine. If you walk out of the fertility office with an unexplained diagnosis, I want you to know that you're not alone, but also I want you to really think about what else could be going on. It doesn't mean, oh, I'm fine, I'll be able to get pregnant because they didn't find these things, my tests were normal. It means something that's harder to get to the root cause of is going on. What can you do to take control of it? Can you get to a diagnosis or not? The treatment recommendations are there for a reason. That's what is studied to shown to benefit. You either need to increase eggs and sperm, consider doing IVF. IVF's the only thing that changes environment. That's very important. You should take control of the lifestyle factors where you can to decrease your own inflammation. Sometimes that's with medication, sometimes it's not, sometimes it's concurrent with IVF. That is a complex decision. But I really think it's important that we don't just say, unexplained, okay. We always take the next step and think, do we know why I have this? We think about your age, your egg count. Do those correlate? Could there be something bigger going on? Not just for your fertility journey, for your family, but for your overall health. If I could have gotten to a diagnosis of my celiac a decade ago, I would be in a much better long-term health position. In addition to having an easier time getting pregnant, I wouldn't have a higher risk of some of the more serious complications. So holistically, This may be the sign, your infertility may be the sign that something else is going on in your body. And I want you to make sure that you're doing what you can, advocating for yourself, sharing your symptoms, trying to get to that root cause. Okay, well, I hope that helped give a little bit of perspective on what that unexplained diagnosis comes from and some of my take on it. I'm going to answer a few of your questions that you asked on Instagram on Monday at nataliecrawfordmd. Remember, you can also call and leave a voicemail at 657-229-3672 for our voicemail episodes. All right, I know I need to go to a fertility clinic, but I'm just nervous and dragging my feet. How do I get over this? Number one, I think understand a lot of us do telemedicine or virtual consults, so barrier to entry a lot lower. Number two, we do this job because we love it. We're just regular people. We're on your team. We see ups and downs and really get to know a lot of people. So we're not scary. We want what's best for you. Prepare yourself by getting all medical records or any tests you've done sent to us. Fill out your history and completion. Prepare, your doctor to have all the information they need to help give you the best information. But know that first visit is highly educational. A lot of it is just explaining fertility and the testing, and there's really nothing to be afraid of for that first visit, even though I know just the whole fertility world is overwhelming. I have low ovarian reserve, confirmed with suspected weak ovulation. What do I do now? As your egg count starts to decrease, the signals from the brain are interpreted a little bit differently. And what can happen is it's not uncommon to ovulate earlier and have a shorter cycle, and then eventually take even more brain hormones to get to ovulation and start ovulating later. If you know you have low ovarian reserve and you're starting to see ovulatory changes, it's really important, number one, you complete the fertility evaluation so you have all the information you need and you get realistic information about your treatment options. IVF can still be very successful, especially if you're younger. If you're older, is there a place for optimizing your ovulation with ovulation induction medications? But 100% want to make sure you know the sperm and the anatomic status as soon as possible so you can make this decision. How does Hashimoto's impact fertility? Does TSH rule everything? So Hashimoto's is an autoimmune thyroid disease, and you'll have positive thyroid antibodies, at least at time of diagnosis. Your TSH is the hormone sent from the brain to tell the thyroid gland to make thyroid hormone. So when your TSH is high, it's an interpretation for you. Your brain's not getting enough thyroid hormone, and you need more supplementation. TSH is a good marker of how your brain's interpreting your thyroid status, but it is not everything. It is associated with infertility, regular cycles, pregnancy loss, so we do pay attention to it. But also really high antibody levels are a sign that your body has really high inflammation. And I always think, just like this whole episode was, that inflammation does have an impact on your environment and potentially the quality of the egg or early embryo growth and development. So I always say it's important to try to get those antibodies down. Sometimes this can be done with decreasing inflammation by your lifestyle choices, by supplements. Sometimes this is by losing weight. Sometimes this is by taking thyroid hormone because you're stopping those thyroid cells from being really active. Therefore, the antibodies don't have as much to attack. So in Hashimoto's, it's not that TSH rules everything. It's really the whole body picture of inflammation associated with that autoimmunity that can play a big role. Okay, friends, well, I hope this episode helped you a little bit. Would love to hear your questions on it. So check out the Instagram at nataliecrawfordmd on Monday so that you can ask your own questions. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow FFS-For Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.